So very good morning. Very good morning to one and all. Today we'll be discussing about the mandibular condylar fracture. All right. So about the condylar fracture, the treatment of the condylar fracture is has always been controversial, whether to go for an open reduction or a closed reduction. So the question is still a controversy. It comprises of 25 to 30% of maxillofacial trauma, and the condyle is growth center of the mandible. Okay. So condyle is the only growth center found in the mandible. Coming to the incidence, the condylar fracture has more incidence of around 21.1 percentage, close to your body and ankle region. Why? The propensity for a fracture for a condyle is more because of the concentration of tensile strains is more in the subcondylar area. So when force is acted on the mandible, all the force will get compensated or accumulated on the area where there is maximal tensile strains. So we should precipitate a fracture of the condyle. Okay. So that's what I've just told. Here there is a picture where we can appreciate that one patient is getting a blow on the symphysis region. The forces in the symphysis region will get dissipated from the symphysis region towards the bilateral condyle, where the tensile strains are more concentrated. So the patient precipitate with the symphysis and bilateral condylar fracture. This is also called a guardsman fracture. Why it's called the guardsman fracture? Because when guards, when they used to take, when they used to march around the ground for more than 1 or 2 hours, they will get emaciated and they will go unconscious and get a blow on the symphysis region, which will cause bilateral condylar fracture. So we have the symphysis and bilateral condylar fracture there. So that is called the guardsman fracture. Other scenarios are if you're getting a hit or blow on the one side of the mandible, the forces will be dissipated towards the opposite side of the condyle. So if you get a hit on right body, you are likely to develop right body and left subcondylar fracture. If you are getting a hit on the left body, you'll get a fracture on left body and the right subcondylar fracture. So these are the mechanism and patterns of injury of condylar fracture. So we have an array of classification for describing the condylar fracture. So we have the Rowan-Killy's classification. So we have the intracapsular fracture and the extracapsular fracture. Intracapsular fracture, which is a part of the condyle which comes in contact with the articulating disc. So that is the intracapsular fracture. Extracapsular fracture, the part of the condyle away from the articulating, that is the condylar neck mainly, and subcondylar region or the lower subcondylar kind of fracture. Then we have a fracture with injury to the capsule ligament. We have the discomalleolar and ligaments is there, meniscus is there, and fracture of the condyle with the adjacent bone. So fracture of the condyle with fracture of cranial forces. So these are the variations of condylar fracture mentioned in Rowan-Killy's classification. Yeah, so this is one more picture where we can appreciate the pattern of condylar fracture. In the first picture where there is subcondylar fracture, the pattern we are seeing. In the second picture we are seeing the variation of high condylar fracture with the fracture of the condyle above the condylar neck. Now, next is a classification given by McLean in 1952. In this fracture, the condyle is fractured, but there is no displacement. Is seen from the condylar head towards the glenoid fossa neck of the mandible. In that second variation, where there's a slight deviation, angulation exists between the condylar neck and the ramus. Then third fracture showed there is a deviation plus displacement. There is an obvious overlap between the condylar and next segment at the fracture ramus. So the fourth segment where there is a displacement, deviation, and dislocation, fracture dislocation of the condyle from the glenoid. So we can appreciate. So this is the picture where there is a, in the picture A, where we can see there is a fracture of the condyle, but there is no displacement. In the second, there is a slight displacement. Third, there is a slight deviation, and the fourth, there is a fracture dislocation. Fifth classification, that is the comminuted. The fracture get dispersed into multiple pieces. So that is the comminuted fracture of the condyle. The next one, classification is the Wassermann's classification. Wassermann's classification basically describes about the angle between the fractured condylar neck and the ramus. The angulation can vary from 10 to 45 degrees, so there is not much deviation. The type 2, where the angulation is from 45 to 90 degrees, where we have it will be very difficult to reduce. And type 3, the fragments are not in contact at all, so the angulation is even more than that. Yeah, and the capsule obviously will be torn and the open reduction is advocated. Type 4, where the fracture head articulates with the articulate elements, and type 5, vertical oblique fracture of the head of the condyle, which is a rare condition. The next classification, that is Lindahl's classification, that is mentioned in the year 1977, where he described the fracture of the condyle according to the level. There is a condylar head fracture, the condylar neck fracture, and the subcondylar fracture. The relationship of the condyle fragment towards the mandible also. So that is the undisplaced fracture, deviated, displaced with a medial overlap, displaced with a lateral overlap. Lateral posterior overlap is possible without a contact between fracture segments. So basically, the medial and lateral overlap that happens because of the pull of the pterygoid muscle. Pterygoid muscle, pull around, there will be a most commonly medial overlap, but in some cases there may be lateral overlap. Anterior displacement also due to the anterior pull of the lateral pterygoid muscle will also be there. And the relationship of the condyle head towards the fossa, no displacement and injury to the articulating meniscus. The problem with the injury to the meniscus is the condylar stem will come in direct contact with the articulating fossa, and it can further precipitate into ankylosis if the patient doesn't go for adequate mobilization, or the fracture of the condyle that occurs in the case of young age, where the growth potential is still patent in the articulating fossa or glenoid fossa region. The next classification is given by Thoma in 1945. The condylar fracture, which is again capsule, is the extras capsule, green stick, and without displacement of the condyle. With displacement of the condyle, move a lateral, medial, forward, and backward, or there is a gross telescopic or overriding segment of the fracture can be appreciated. And with the dislocation in the lateral medial direction, the intracapsule is the complete fracture, dislocation of the condyle, dislocation of the fractured part of the head of the condyle will be there, or dislocation in the forward direction, either anterior to the articulating eminence or posterior towards the articulating eminence will be there. Okay, now coming towards clinical features. The clinical features that you can appreciate when there's unilateral condylar fracture, well, there will be pain. Obviously, there will be pain, there will be swelling, there will be hematoma, there will be Christmas and deviation of the mandible towards the fracture site where of the lateral will be that. And the middle dislocation of the joint may also be the lateral muscle. So we'll give a characteristic hollow on the preauricular region. There will be premature bite or gap of motion on the affected side. There will be a provision of motion, and there will be a prospect of the contralateral side. Then the repetition of the TMJ facial asymmetry will be there. The bilateral open. So the investigation of the diagnosis of condylar fracture we have OPG will be there. Then worst on CT scan and MRI scan will be there. Then treatment of the condylar fracture. So that's what the condylar fracture. is always it is always controversial. It's always controversial. So, conservative and surgical management. Conservative management is the observation parts of the patient in operation for 3 to 4 weeks and advise the patient any kind of soft diet for a short period of time. Surgical treatment will open the corner through an extraoral approach. Will visualize the fracture, reduce the fracture, fix it with plates, screws, or wires according to the severity of the fracture segment. So this is a picture where you can appreciate that we are doing a close section of the condylar fracture where the arch bar are secured on the upper and lower segment, and the occlusion is brought back to the previous anatomical relationship by the action of elastics. Elastics will be guided, which will pull the mandible back to occlusion. Inadvertently, it will replace the fractured condyle back to its normal anatomical position. After achieving the adequate satisfactory occlusion, will give IMF or intermaxillary fixation for 3 to 4 weeks. Yeah.